Welcome, everybody. This is Diana Jallis, and I'm thrilled to have so many students here to listen to our amazing guest speakers today for the IHI Open School Chapter seminar. The Frontier Nursing University IHI Open School is part of the global community of like-minded individuals with courses, networks, and training. The Frontier chapter is free. It's a club for the Frontier community. It joins alumni, students, faculty, and preceptors together. Sorry, I got muted. I know everyone wants to mute me. Except now we have a tremendous amount of feedback. So if people can mute if they're not speaking, that'd be great. Okay. So the Frontier Nursing University IHI Open School Chapter is an opportunity for us to join together across the curriculum, across all sectors of the Frontier community. We hold activities throughout the year to come together and carry our knowledge back to our home communities. Today, we are especially excited to welcome our two guest speakers. Lana Bernat is currently in our Postmaster's DNP Class 22. Lana is a CNEP graduate. She is a U.S. Army Nurse Corps officer, previous Nurse Corps officer. She's currently living in Hawaii and preparing to begin her first job as a certified nurse midwife. Lana brings 21 years of nursing experience. She has a master's of in healthcare systems, which she received in 2005. She has 14 years of labor and delivery experience, 4 years as a case manager, and 2 years as the chief of quality in a large ambulatory care organization. Lana is our first student director of the Frontier Nursing University IHI Open School Chapter. She's been responsible for finalizing the Open School Charter, for leading many of our meetings and of our chapter events. Recently, we've been recognized by the Lown Institute as a Right Care Action Week champion. And this award would not have been possible without the hard work and dedication of Lana. Our second speaker tonight is Matthew Mattner, the Chief Operating Officer of the Cleveland Clinic Lutheran Hospital in Cleveland, Ohio. He is the former Chief Executive Officer and Commander of the Fort Drum Medical Department activity. Some exciting facts about Matthew are that he is U.S. Army retired for 27 years and 27 months of service. He commanded 2 fixed facility healthcare organizations, commanded a helicopter air ambulance company, commanded a tactical field healthcare organization, and deployed it to and from Bosnia. He has a Master's of Science degree in aviation safety, 6 years of experience in compliance inspection, 2 in aviation, and 4 in the Army. So I thank you, and we're thrilled for your generosity of time and expertise. Thanks for sharing with the IHI community at Frontier. And without further ado, I'll pass to Lana. Thank you.
Thank you. Aloha from Hawaii, and we thank you for joining us in a session focused on high reliability in healthcare. I will be presenting from the perspective of a nurse, clinician, and professional in healthcare quality, while retired Colonel Mattner will be joining us from Ohio, presenting from the perspective of an accomplished aviator and healthcare executive and administrator. Our intent is to help you understand the basics of high reliability in healthcare, and ultimately, we will be asking you to critically look at how you can help your own organization become more reliable. Here's the problem. 98,000 deaths every year were attributed to shortcomings in the healthcare system based on an Institute of Medicine report published in 1999. Despite many safety initiatives that were implemented since that report, the incidence of preventable death remains. A recent study by James, published in the 2013 Journal of Patient Safety, estimates that medical errors result in more than 400,000 deaths per year and an additional cost of $1 trillion. The IHI Global Trigger Tool for Adverse Events was used to mine the data in this research. It's important to understand that this is an estimate, which the American Hospital Association pointed out after the study was published. Matt will talk about the difficulty with accurate numbers for healthcare later in this session, so more on that soon. Although experts may debate about these numbers, there is an agreement that the 1999 Institute of Medicine report was likely underestimated, and we all agree the numbers are too high. If James' estimates are correct, 400,000 preventable deaths per year equates to 1 death per hour per state. The headlines in the news remind us of our struggle in preventing errors that lead to patient harm, and the U.S. is not alone in that struggle. The problem is rarely with an individual. Rather, the problem lies within and between our systems. I'm going to ask you to listen to the words of Gabriel's mother, who experienced firsthand the tragedy that happens when our systems are not reliable. The nurse grabbed the recliner, jerking me awake. "Leilani, you have to get up." I heard code blue and the room filled with people. In that instant, I knew he was gone. The next hours were awful. My sweet, joyful boy had become a corpse hooked to machines. I begged for this not to be happening. I wanted to wake up stiff and uncomfortable in that stiff, ugly blue chair and realize this was just a very bad dream. But this was worse than a nightmare. My 20-month-old son had just died in one of the country's leading hospitals. On Thursday, he was sick. On Tuesday, he was dead. When he was admitted to the hospital, white circles with wires were stuck to Gabriel's bare chest to monitor his breathing and heartbeat. Every time he made the slightest wiggle, the alarms went off. Every time we would almost be asleep, the racket and worry would start again. We had already spent sleepless days and nights in the hometown hospital where Gabriel had been misdiagnosed again and again. But now we were at a hospital for children. Finally, I felt safe and very tired. I'm sure the nurse could see how tired I was. She wanted to take care of me too, so she did the logical thing. She turned off the sound on the alarms next to Gabriel's bed. I thanked her when she did it. I was so grateful for the prospect of sleep. Later, doctors and administrators would tell me that she had unknowingly done a lot more. She hadn't just turned off the blare in the room. She had turned off all the alarms everywhere, in the room, at the nurse's station, and on her pager. The manufacturer of the monitors later explained they didn't think anyone would go through 7 screens to turn off the alarms, so they didn't bother to include a fail-safe to stop her. They were wrong. So when Gabriel's heart stopped beating, there was no sound, just quiet. Nothing woke me until several minutes had passed and the nurse found him. Then I was jerked awake and the room filled with people and panic. This is a tragedy for Gabriel and his family, and something that none of us who work in healthcare ever want to experience. The victims of these unreliable systems are not just our patients and families, it's us. There are second victims in medical errors, which has further impact to the health system. Some of the symptoms that we experience as a result of being a second victim include fatigue, sleep disturbances, rapid heart rate, increased blood pressure, rapid breathing, muscle tension, frustration, decreased satisfaction in our jobs, difficulty concentrating, flashbacks, loss of confidence, grief, and the list goes on. Outcomes for second victims vary. Some will leave the profession altogether, some will survive, some who are perhaps more resilient will thrive. At least half of all providers will experience it at least once during their career. Experts estimate that in healthcare, errors or omissions or failures to accomplish an intended action occur on average 10 to 20% of the time. Compare this with 0.0001% in the airline and nuclear industries. Clinical studies by the RAND Corporation and other research show that for many medical conditions with well-defined criteria, such as things we have clinical practice guidelines for, only ever really deliver 50% of the recommended care. Complex high-risk industries that have the ability to go long periods of time without accidents are what we define as reliable. Examples include air travel, nuclear industry, and amusement parks. You can look at reliability in terms of processes and outcomes. For example, of the total number of patients who were on a ventilator, how many patients did not develop pneumonia? This measurement looks at reliability to achieve an outcome. So why, when we look at healthcare, why would we look to the airline industry? At first glance, you might think, okay, airlines are mechanical. That's what airplanes are. It's different from a human body. That's a valid question. Let me explain why. Commercial aviation has focused on safety culture over the past 30 years because in the 1970s, they discovered that the majority of crashes were not due to mechanical failure, but due to failed communication. Now think about what the Joint Commission has been telling us about the most common cause of sentinel events across healthcare. It's communication. So while clearly airplanes are different than the human body, they don't operate an airplane without human intelligence and interaction. So healthcare can use lessons learned from other industries, such as the airline industry, to make healthcare more safe. Now you know why we are reaching out to experts like Matthew Mattner, who understand both aviation and medicine. And I'm going to turn the presentation over to him for the next few minutes.
Thanks, Lana. Good evening, everyone. So healthcare is a complicated organization or system of systems, but aviation is just as complicated. Am I advancing the slides or is someone else? There you go. If that's okay, I'm new to the system, so if I'll just say next slide for the next presentation. So airports are complicated. If I were to say flight 123, taxi to runway 6 left via Romeo and Golf, hold short of 6 left. How many of you could get from the terminal to the runway that I would like the aircraft to depart on? Communication is key. Standard communication is key. We in aviation follow a simple mnemonic for getting a clearance craft. Your clearance limit, your route, your altitude, your frequency to contact control, and the time of the departure. Things are somewhat routine, but you know what to expect. Next slide, please. So as complicated as aircraft are, I think operating rooms are even more complicated. I am more comfortable in a picture on the left with all the gauges, dials, gizmos, and things in a cockpit. I'm still finding my way around an operating room. But look at the amount of technology that we have available in healthcare. How do we manage that? How do we manage the tasks at hand? Next slide, please. Healthcare is complicated. Think about the system of systems of healthcare, how it's all interconnected, how the environmental services and housekeeping are so important to infection control, as much as when you're putting a PICC line in, the scrubbing, the sterile field, all the things that go into preventing that infection with a PICC line. The EVS worker is just as important. How we communicate between departments. How do you do a handoff? Is SBAR the right way to do it, or I have the baton? How do you make it systematized or routine? Next slide, please. We talked a little bit, or Lana talked a little bit in the beginning about how deadly healthcare can be. On the left side of the chart shows commercial airline deaths on U.S. soil from 2005 to 2016. In total, there are 54 deaths accountable to commercial aviation. I'm talking about the big airliners. You go through TSA to go to a gate to get on an airplane. It might be a regional, but it's the commercial airlines, not charters or other airplanes. 54 deaths. Compare that to healthcare in the U.S. on U.S. soil. Researchers find it difficult. We don't have a ICD-10 code for healthcare error, so that's not what goes on a death certificate. But if you think about your organization or perhaps your state, I'm willing to bet that we can come up with more than 54 deaths in 13 or 14 years, contributed specifically to accidents or errors, not counting those who die from complications that may have been inappropriately managed or recognized too late. But the actual accidental deaths. It's difficult to put a number to it, but if we can agree that healthcare is not as safe as aviation, I think we can find common ground and perhaps a starting point to move forward. Next slide, please. So here's another comparison. Nearmisses. From the Wall Street Journal in fiscal year 16, which ran from the 1st of October of 2015 to the 30th of September in 2016. The number of close calls on runway incursions. Very, very low error rate. But in healthcare, how frequently do we have close calls? Next slide, please. So Lana talked a little bit about the evolution of aviation. Back in the 1970s, as NASA and the FAA and the NTSB were beginning to really pay attention to safety in aviation. The flight deck was male dominated. The flight crew, the cabin crew was female dominated. And if you think back to the cultural norms, men and women didn't really work together. It was still before Gloria Steinem and women's liberation and where we are today with equality by gender and many other ways to define us. Pilots were trained in the military, very autocratic, very authoritative. Simulation of testing people in unusual situations was limited, and today, multi-gender, multinational flight crews. We have pilots that never served in the military that have all of their training through civilian flight schools. And the virtual reality simulation capabilities to put people through the difficult paces of difficult situations is phenomenal. An important one here, the National Transportation Safety Board, the organization that investigates the serious accidents. It used to be a part of the Department of Transportation. Now they're a separate agency that makes recommendations to the FAA. The FAA is the regulatory authority. Would it be good if CMS had the same regulatory authority as the FAA did, having CMS dictate some of the procedures or standardization in the way that healthcare was provided? Next slide, please. One of the ways that safety in aviation improved was through crew resource management, or as it was first called, cockpit resource management. There have been about 6 generations of crew resource management following. United was the first to develop a cockpit resource management after a 1979 NASA workshop. As Lana said, by this time, in the 1970s, accidents because of mechanical failure were really eliminated. And the accidents that did occur were because of the human factors in aviation. Next slide. So what did crew resource management improve? The collaboration, expressing opinions, challenging mistakes. For some of the autocratic pilots, it was admitting fallibility, that I did make a mistake, or I'm not the all-knowing Oz. Delegating tasks or offering assistance where you see someone needs assistance. There are a lot of tasks that need to be accomplished in an aircraft. Some of the other things that aren't on here in standardization are the sterile cockpit at 10,000 feet. When departing from an airport or landing at an airport, from the ground to 10,000 feet and from 10,000 feet down to the ground, the only thing that is talked about on the flight deck is landing the aircraft or departing the aircraft from the airfield. No talk about the kids' soccer game, no talk about anything else. It's just safely departing and landing with the aircraft, all of its crew and passengers. Next slide, please. So where could crew resource management help in healthcare? Team Steps is a program that follows the crew resource management model. They've taken a lot from the different crew resource management programs that are out there. But there are some specific things that could be developed for healthcare. I would like to see simulation in healthcare. I think it would be pretty cool if you had an orthopedic team who was in the OR and you said, as they were nearing the end of their last OR, we've got one more case and it's an emergency. We're going to bring it in when you're done. Bring in a sim man and put the team through their paces. At the end of the day, they're a little bit fatigued. Throw in some controlled emergencies. Help the team work through those emergencies, see how they react, do an after-action review after that, and make that team better for the next time around when they're working on a patient that has a heartbeat and a family. Next slide, please. Here are some things about changing the culture. The culture in commercial aviation, it took time to evolve. It wasn't, we throw crew resource management in and boom, we've got safer commercial aviation. It was over time, some of the older pilots who didn't want to change had to leave. But it was really a change of the culture, and I was involved in that culture in military aviation back in the 90s. So as we talk about changing the culture, some of the things that could be changed in a healthcare organization and how they're tied to the high reliability principles are depicted on this slide. I think the biggest one for me, if I were to prioritize and begin to work on the left side of the slide, it would be communication. Improving the communication, improving the human factors in healthcare would go a long way to improving the safety of healthcare. Lana, I'll turn it back over to you.
Thank you, sir. Okay, so now that we know that we can learn some valuable things from the aviation industry, how is it that we can translate what they have evolved in patient safety and in safety and move it to patient safety in healthcare? So I'd like to share with you a model that comes from the Joint Commission, some leaders in Joint Commission. And I know that the Joint Commission kind of gets a bad rap out there because they come every couple of years with their white gloves, and we bristle a little bit at that process. But they really are committed to quality across the United States, and they're working hard to provide some of the framework that will help us do that. And so they do have good information available looking at high reliability. So Chasen and Loeb offer this model for high reliability in healthcare, and it consists of 3 domains: leadership, culture of safety, and robust process improvement. And we recognize that there's no way high reliability can happen unless we have committed leaders, all the way from the governing boards to executive leaders, healthcare providers, and team managers at the front line. Leaders must commit to a quality strategy with quality measures and safely adopt information technology. Organizations that build a culture of safety have trust, accountability, the ability to identify unsafe conditions, and then commit to strengthening those systems. Matthew already talked a little bit about the importance of understanding near misses, and that's one of the places in which you can really move the culture of safety in an organization, is to enable people to catch problems before they actually turn into events. So we have to make it painless and make it easy for our healthcare professionals to report problems. Robust process improvement, as trademarked by the Joint Commission, is achieved through an applied methodology. We need both training and understanding of change concepts so that we can spread process improvement throughout an organization. There is a mindset that comes with a high reliability organization. These are the 5 tenets. And I will say this, that culture will trump any strategy you have. So if there's one thing that you have to target, it's culture. But these are the 5 tenets of the mindset, and I'll explain these in brief detail. With preoccupation with failure, everyone focuses on what could go wrong. The organization analyzes and learns from both errors and near misses. The goal is to prevent one from happening, or if it happens, to prevent recurrence. Whether clinical or non-clinical, all staff are expected and encouraged by leadership to identify and actually address problems at the point of care when they occur. When planning change within an organization, one way in which we can be preoccupied with failure is to do proactive risk assessments. One of those might be a failure modes and effects analysis. If you've ever been involved in one of those, that's a proactive risk assessment so that you can learn where the gaps are and close them so that errors don't happen. Reluctance to simplify. In a busy healthcare environment, it is really tempting to come to the easiest conclusions as to why something went wrong. We can say things like, well, we were low staff that day, or we had a lot of high acuity patients that day, or we had a lot of walk-ins to the clinic. And those might be relevant, but if we stop at those first obvious conclusions, we're going to miss much more information that's valuable about our system that creates problems. Reluctance to simplify means that we ask why repeatedly. So one of the tools that you may have heard of is a root cause analysis. You might even bring external people to come in and help you as consultants to go through that process. But it's very important that those who are participating in a root cause analysis include people at the front line who can tell you the most and the best about what's happening at the point of error. Sensitivity to operation means that you have an ongoing concern with the unexpected and you're concentrating on systems and processes. Hallmark actions for sensitivity to operations means that you're closing loopholes where there's potential for patient harm and you're aware of the situation. For example, if you make a change in one area of the hospital, how does that affect another area? So being sensitive to think about changes before you actually march through with them. Commitment to resilience is a concept that we know that things will go wrong that we can't predict and mistakes will happen. And as a organization, you need to be able to bounce back and you need your people to be able to bounce back too. So you've got to have a system that swoops in and minimizes the harm that could happen if something starts to go wrong. One of the examples of that is our organizations who have rapid response teams to come in and help. Another example could be your debriefing teams that come in and support your people when an adverse event happens. Deference to expertise essentially means that you care less about people's rank and position and you care more about what their expertise is at their level. It means that you're not necessarily going to go straight to the top for your information, but you are going to bring the frontline people to the table to tell you how to fix the problem, because people who are close to the problem also often have the right answers for how it needs to be solved. This is an interesting quote that comes from a book about failures that happen in war. On the actual day of battle, naked truths may be picked up for the asking, but by the following morning, they have already begun to get into their uniforms. I think for those of us who've been involved in an adverse event in healthcare or any other kind of industry, we know how this works. The best facts are gathered immediately after the event. As time goes on, the way that our mind works, our memories get fuzzy and we mix up what we think with what actually happened. And so this is a good thing to remember, that yes, we have to be sensitive to those who went through the event, but we need to gather the facts as soon as possible to really be able to solve the problems. So high reliability is not just a project. You can't put it on a line item on a couple agendas across an organization and make high reliability happen. It actually is a journey, and it's a journey not over 1, 2, 3 years, but more likely at least a decade. And some of the organizations that you'll see us list later on have been on the journey for about that long, and it's been amazing work that they've been able to do with high reliability systems. High reliability is about systems and people, and I think this is nicely captured by Cincinnati Children's Hospital, who describes their journey as this: our journey toward becoming a high reliability organization focuses on improving reliability through better process design, building a culture of reliability, and leveraging human factors by creating intuitive designs that help people do the right thing. So the same professionals who developed the HRO model for the 3 domains also show this maturity model to help organizations visualize their progression toward being a high reliability organization. This is a focus on robust process improvement, and you can see at the beginning stages an organization may not even have a formal approach to quality management. They may not really have people who understand it, except for maybe a handful of people in a quality department. But as an organization matures on their journey to become an HRO and they are approaching high reliability, you can see on the right-hand side that robust process improvement tools and processes are fully embedded throughout the organization, and it's even connected with career advancement. This is a slide that shows you in numerical terms what levels of reliability look like. So in level 1, you may have an 80 to 95% success rate. Level 3, 99.6 to 99.95. And then if you look in level 6, that's an impressive level of reliability. So I'm guessing you're wondering, what's a reasonable goal for healthcare? Because how would we ever achieve a near 100% success rate? What's realistic? There's an IHI white paper available that you can go look at IHI's website, and it's listed below there by Nolan, Rosen, Harden, and Griffin. It was written in 2013, and they looked at what the levels of reliability look like in terms of the design. And so you can see in a level 1 reliability that an organization has the right intent, and they may have standardized protocols and things, but there's something missing. If you move on to level 2, it's an organization that's designed and informed by reliability science and human factors research. So these are things like you open up your encounter for your next patient who's coming through, and it automatically sends up a message and says, hey, this patient's due for a colonoscopy. It's because the system knows how to gather the patient's age and the last time they've had their screening test. In an HRO, which they consider to be a level 3 for reliability, it's really the mindset that helps change the information that you actually get, that then informs your processes, your culture, and your process improvement throughout the organization. So you've maybe had this thought as we've been talking, it sounds like we're looking for perfect because we're looking for zero preventable harm in high reliability. But that's not quite what we're looking for, but it is a valid concern when you're talking about it. So if you are having a discussion about high reliability, you may appreciate the following statements to help you kind of navigate that conversation. So when we set the bar at 100% for something, it's not long before we realize that a process gets very complex to reach the 100%. And as processes become more complex, it's hard to sustain it. Then we feel like we failed, and then we get cynical and we experience fatigue, and then it's just kind of one of those things that didn't work. So here's what you need to know. There's a difference between measuring processes and measuring outcomes. And you don't necessarily have to have 100% performance on a process to achieve first-rate outcomes. And you're not going to choose everything to be your high reliability targets in your organization. High reliability doesn't mean that you're perfect or that you never have an error in a process. An organization who's on the journey to becoming an HRO really sits down and looks at, okay, where are our greatest risks? And now that we know where our greatest risks are, what kind of processes can we circle around these risks so that we can prevent some of the most dangerous harm events that can happen to a patient? That's where it starts. And then how do you determine, well, how many times do we have to do a process right to actually get the outcome? And unfortunately, there's no cookie cutter for that. It's important in process improvement that you measure both your processes and your outcomes, and you'll be able to track within organization what performance level you need in order to achieve your outcome. So accepting a less than perfect design that is sustainable is what you're looking for. And so one of the ways that you can do that is go to your front line and ask a handful of people if they can explain a process to you. If they can explain it and you can achieve 95% or more on that process, it's most likely you're going to be able to sustain it and get the outcomes you're looking for. So again, it's a journey towards high reliability, not a pursuit of perfection. These goals for reliable healthcare are what healthcare professionals and patients want alike. We don't want to cause harm. We don't want to contribute to needless death or additional treatments because of errors. We don't want patients to have a poor experience or experience a lot of pain. We want them to achieve optimal health. And what we have in the HRO model and the mindset is a framework to help us get there. This is what metrics might look like in an inpatient setting. You might target preventable harm events such as wrong site surgeries, retained foreign bodies, pressure ulcers. You might also look at central line associated bloodstream infections, catheter associated UTIs, or for your workplace safety, you could look at moving your bloodborne pathogen exposure to zero. These are all examples of what you might do in an inpatient setting. And some of the high reliability organizations have done exactly this. If you remember, I brought up ventilator-associated pneumonia earlier, and we used to accept a certain percentage of patients are going to get pneumonia when they have ventilators. But then once a bundle, preventative bundle was implemented at the bedside, some of these organizations have been able to get their ventilator-associated pneumonia to zero for more than a year, which is impressive. And maybe 10 years ago, no one would have believed that. So this is the approach we need to take when we're looking at high reliability in our organizations, that there are some metrics that it is achievable. In the outpatient setting, it's a little bit more elusive to come up with metrics right now, but one of the greatest risks we see in ambulatory care is in transitions of care. So readmissions for select conditions is something you can look at. You can also look at accurate and timely diagnosis for certain things. It's all going to depend really on what your own setting is and the risk assessment that you and your team performs. Matt, I'm going to let you do this one.
Thanks. So how do you move those metrics? How do you get closer to zero? And again, we're going to talk a little bit about culture. Some of the elements that change the culture in commercial aviation can be adapted in healthcare. Some people argue, as Lana mentioned, the big difference between flying an airplane and performing heart surgery is huge, and I wholeheartedly agree that flying an airplane is very much different than surgery. But we prepare our air crews to operate complex machines in unforgiving environments where a minor error can be catastrophic. Could we train our surgical teams differently to work in an unforgiving environment where minor mistakes can be catastrophic? Whether aviation or medicine, an error can lead to death. And perhaps we can use some of what one highly reliable system uses to improve another. It'll take time. Obviously, it will take time. Aviation wasn't highly reliable overnight. But we can adapt, and we can learn, and we can improve.
The benefits of high reliability expand beyond zero preventable harm. We also see the benefits in our culture as we enjoy more teamwork. We're more effective, more efficient, our customers are more satisfied, and we do better in documentation. And by default, because of all the process improvement that we do, we also tend to do better with compliance. The journey toward high reliability is challenging because transformation takes time, and it's energy depleting at times to translate reliability to healthcare. It's a long journey. So if we're looking for immediate gratification, we're in it for the wrong reasons. Variation is also part of our healthcare culture. We've embraced clinical autonomy, and across the board, we emphasize hard work and creativity. And we have done well in many ways, but the statistics tell us that we need to do better. So let's talk a little bit about the cost of quality, because when you're talking about putting a lot of resources and energy into specific things in your organization, the cost becomes part of the conversation. So how do we focus on our resources so that we're not investing in things that increase the cost but don't get us the outcomes we're looking for? The sweet spot is shown in this graph on that little blue circle. The green curve demonstrates what the cost of implementing quality is. The gold curve shows the cost of fixing problems that occurred. You see that starting on the left upper quadrant there. And then the red curve illustrates the total cost of quality. So we know that resources are limited and healthcare is a business, and there's no way to look at this equation without taking care of both. Healthcare organizations definitely have difficult decisions to make here. So if you operate on the left side of the chart, you'll have low quality, but there's still going to be a cost to that because the errors and inefficiencies that you have a price tag attached to them. If you offer or operate on the far right-hand side of this chart, you're going to spend an awful lot of money in order to achieve that high quality, and there is a point at which cost containment becomes unmanageable. So back to high reliability. Organizations have to be selective in how and where they apply their improvement processes so that they can achieve both quality outcomes and control cost. And part of the equation is also learning how to be a lean organization where you identify and eliminate excess waste. And that model that the Joint Commission offers, that part of the robust process improvement includes lean principles. Here's a couple of Trailblazers that are in the news. If you're interested in looking them up, you can just put it into Google and you can read about it. Memorial Hermann is one of them. The South Carolina Hospital Association has committed to high reliability across the entire state, as they have created a certified zero harm awards program for hospitals to participate in. Johns Hopkins, Cincinnati Children's, and of course, Matt's home place now, the Cleveland Clinic. So in summary, we covered that unreliability affects patients, professionals, and organizations. We agree that healthcare is complex, and we agree that there is something to be learned from our other industries, such as aviation. We reviewed the 3 pillars of the HRO model, which include leadership, culture of safety, and robust process improvement. And these organizations listed below are just a couple of the resources that are available to you to help your organization improve reliability. What we're asking you to do is to join us in making a difference for our patients, ourselves, our colleagues, and our organizations. Assess reliability in your setting. Be the leader who sets the tone for quality and safety. Lead and participate in environmental changes that promote transparency. Remember that most problems are a result of a system, not individual negligence. Speak up and ask others to speak too. Lead and participate in robust process improvement and quality improvement strategies. Look at your system and area for high risk and problem-prone processes that could lead to an adverse event. Work with your team to facilitate change around these processes to achieve high reliability. Be the change and inspire others to join you. And we'd like to invite your questions if you have any for either one of us.
The chat has been on fire and fabulous.
So I've got a question, Lana.
Sure.
How do you know when your journey is over? We talk about being on a journey to high reliability. How do you know when it's over?
It's like chasing the rainbow, sir.
Absolutely. It is. I don't know that it's a journey that any of us will ever end. In aviation, we're always looking for a better way to do things. We're looking for a safer way to do things. We're picking apart processes, checklists change and adapt. Procedures change. The non-fatal accidents are investigated, and new policies, procedures, and rules come out of the FAA. So it's a never-ending journey. You're right, it is chasing rainbows, but for the right reasons and for the right outcomes.
True.
I have a question for both of you with regard to the concept of persistent mindfulness and preoccupation with failure. How do you balance preoccupation with failure with positivity and optimality and searching for appreciative things that are working? Because that concept seems to be in conflict with appreciative management, where you're celebrating successes and looking for the successes.
Well, I think we can talk about patient safety. Like, one of the things that we did at Fort Drum was we had a patient safety award system, and we had that award system built around near miss reporting. So we called them best catches. And that was really a great opportunity to celebrate success and get the team to start focusing on how to prevent. And I think part of it was the fact that we worked in an ambulatory care setting, so we were not in a hospital where we were dealing with real, a ton of actual errors. Our risks were different, and we had to focus on a little bit different of a different mix than we would have in a hospital setting, where it might be a little bit more challenging to turn that tide. But our goal was to get at least 60 to 70% of our reports to be near misses. And in fact, we turned the tide to, I think at one point, over 90% of our reports were near misses.
What we do here at the Lutheran Hospital now, we do a daily safety stand-up every morning at 10:30 where we review our elopement risks, our high-risk patients. We look at each of the safety events that was reported over the last 24 hours. And a portion of that is good catches and call-outs. So while we're talking about the errors very briefly of our initial reflections on any of the safety reports and currently what's risky in the hospital, we're also patting each other on the back, saying thank you for identifying that. Great catch for noticing that. Really appreciate your caregiver who stayed an extra 30 minutes to help us work through a problem. So that's and you've got to change that culture of gotcha, or hey, get your fingers out of my rice bowl, to hey, look at the rice in my rice bowl. Does anything look out of place? Could you help me solve this problem? Because I think it's going to cause harm, but I'm not really sure what to do with it. And so somebody made a comment about culture change starts at the top in the chat, and that's absolutely correct. The safety reports, we sent a patient down to radiology and they had to wait 40 minutes. Oh my gosh, we were so busy that day. But it was really helpful that your unit coordinator called down to our receptionist and asked, this patient's been down there a little while, is something going on? Really highlighted that we needed to get out there and just let them know that we were swamped, we were busy, we had a lot of ER work. And so it's a delicate balance from getting the reports, encouraging the reports, and then what do you do with the reports? If it's an aha, gotcha, or what is wrong with your unit, why can't you fix these things, then it will become a negative. The mindfulness, it'll be protective rather than proactive.
Thank you. Those are great examples of how to combine both the preoccupation with failure and with the positive nature of promoting safety at the same time, because the picture you painted clearly explains how they do coexist. Thank you.
Rosa, you had something?
Sure. I noticed that Mr. Mattner had said about the healthcare and aviation, and you also, Lana, mentioned, developing this culture of safety. And I wanted to know, does anyone do any perspectives on the outside, as far as, I know we do a lot with the clinical side, but also catching these folks before they get so sick that they have to dial into the healthcare system, because the bodies are so complex. It's hard to, I noticed one of the comments was like, develop a kind of aviation, you kind of follow a set rules of what may happen, what could happen, but there's so many crazy variations. It probably is that same way in aviation, I can imagine, with the weather and all those things, but trying to redo our culture of, really permeate the preventative health care that we need to put in, because I work in kind of rural and mobile. I go to people's homes and I see this culture of don't go in until you're really, really sick. So I think that needs to be helped, because it costs so much and people are really, trying to not get a new diagnosis with a new hundreds of dollars medications, or they can't afford their medications. So healthcare is kind of such a big shell, such a big nut to crack when we're looking at safety. I think it starts, way before the hospital also.
Mm-hmm. Yeah, I definitely agree. The population health goals, I think, give us some kind of measurements that we can work towards, because really the ambulatory care side of the house sometimes can be fragmented for patients to get their care. So if you look at things like the patient-centered medical home concepts and the commitment to population health in those kind of settings, because many of them are certified in health quality as well. So I think that's what you're looking for to target, is really looking at the population health measures, and depending on where your setting is, zoning in on some of those that might lead to unexpected admissions. And one of the population health measures that comes to mind there is childhood asthma. And what can we do in ambulatory care to manage asthma better, to decrease the number of emergency room visits and hospitalizations? If we're managing their asthma appropriately in the ambulatory care setting, we should be able to decrease those numbers.
Yeah, Rosa, along those same lines, we have about 30% of our patients that come to our hospital are from the Hispanic community, and we have a Spanish-speaking clinic. And the providers in that clinic are challenged with diabetes in the Hispanic community. And so we're looking at ways, how do we change that culture, really? It's how do we get to the kids? How do we get to the parents? Really changing the diet, changing the way they eat, encouraging more exercise, encouraging going through the whole digestive system, more of them, especially the men, to come in and get their colonoscopies. In the Hispanic culture, getting a colonoscopy is not part of the culture. And so we have some wonderful Hispanic physicians who are breaking down the barriers. We're working with the local Spanish radio station, doing outreach into the community, and changing a culture in a community. That is also a long journey, and I very much agree with Lana. The population health, that is the direction that U.S. healthcare is headed.
We have a couple of minutes left. Does anybody else have any questions?
I just want to say thanks for letting me participate, share a little bit of our story.
Hey, we're happy to have you.
You are an amazing woman. I hope I get to work with you again.
That would be awesome.
To compete with us. No, but thank you both.
I consider it
very fortunate.
Yeah, I consider it to have been a privilege. At the time, I didn't see my journey going through working as a quality professional, but it didn't take me long to get really passionate about the work. So I enjoyed it.
Yeah, thank you. We had over 60 attendees and lots of chat, and
yeah.
We're looking forward to seeing how you all integrate the concepts of high reliability into your DMP projects. And thank you for the stimulation and for your generosity of time and expertise, Matthew Mattner and Lana Bernat.
Doctor,
Thank you.
if I could just answer Crystal's question about measures versus outcomes.
That'd be great.
So if you go back and you look at a few slides earlier that looked at some of the outcomes we were talking about with CLABSI zeros, CAUTI zeros, zero harm events. Those are the outcomes. But what are all the processes and pieces of your system that get you to that? What gets you to zero central line infections? And where does it start and where does it end? And what are the measures along the way that you need to measure that will eventually get you to that outcome? This is a discussion we're currently having, is what should we be measuring? Outcomes is part of it, but should we be more granular or be measuring things along the line from when the patient comes in the door to when they get the bill at home? What truly should be the metrics that we're looking at? Outcomes are a piece of it, but they don't tell you the whole story. the story is very difficult to pick apart. And so finding the right measures, I think, is unique to each organization. Measuring along the way to the outcome to help you identify where you need to make adjustments to get the outcome you desire.
Right. So things like that you might look at if you were looking at central line infections might be the timeouts prior to it. Does the timeout include a pause to make sure that everybody is sterile, that nothing has been broken? You could look at the cleanliness of the environment of the rooms in between patients, all sorts of things that you could look at in the process.
Time the scrub. You name it.
Yep. Okay. Thanks, everyone.
Thank you.